Hello everyone, my name is Tim Rowland and I'm a Masters of High Performance Sports student at the Australian Catholic University, and today I just wanted to talk to you a bit about modifiable risk factors for initial and secondary ACL injury. So in terms of a bit of background about this topic, we know that ACL injury has significant consequences for both the individual and the team. In terms of the individual, it's a 9 to 12 month rehabilitation, so they're out of the sport that they love and they have a lot of negative, often psychological consequences of this. And in terms of the team, they lose a player for a long period of time. So we know that the longer, the more players that a team can keep on their side, the better that they normally do. So it's very important to prevent these sorts of injuries. Unfortunately, it's also quite a common injury, considering in field-based team sports that require a lot of agility. There's stats that show that up to 3 to 4% of people will suffer an ACL injury, so that's a relatively high injury rate. And unfortunately, this injury rate is increasing in incidence as well. And a really scary stat is that after they've had an injury, the re-injury rates are very high compared to other injuries. So up to 1 in 4 athletes who are under 25 who have an ACL injury will have another one if they're returning back to their sport that is an agility-based sport. So that's a very scary statistic considering how severe the consequences of the injury are in the first place. So therefore, to reduce the injury rates for ACL, it's very important to identify risk factors for injury so that we can then try to target those risk factors. But unfortunately, up to this point in time, most of the studies on ACL risk factors have focused on demographic and surgical risk factors. So that's unfortunately things that we often can't control. So we know that young females are way more likely to have ACL injury, and then yeah, it's also surgical risk factors too, once for re-injury. So we can't control these things as an S&C. We just need to be able to control their performance and their neuromuscular aspects. So we want to look into the things that we can control, and that's what I wanted to do with this review. And so once we can identify these risk factors that we can control, we can then screen the athletes for them and identify the athletes that are potentially at high risk, give them injury prevention strategies, and then that will hopefully lead to a reduced injury risk, which the research has shown that neuromuscular programs do help prevent injury for ACL. So therefore, that's what I wanted to do with this review. In terms of the aims of it, I wanted to look at all of the research on modifiable ACL risk factors and try to answer the question, what are the objective and modifiable risk factors for initial ACL injury? And then I also wanted to look at the objective and modifiable risk factors for secondary ACL injury. So therefore to establish return to play criteria. And then I wanted to compare those initial and secondary risk factors to see if they're the same and see if it's the same sort of underlying neuromuscular control or biomechanics that might be involved in both. And I think that once we can determine these things, we'll be in a better position to try to prevent ACL injury. So for this review, the key stakeholders were the Australian Rugby Sevens players, because I did my internship with the Australian Rugby Sevens team, and so I wanted to produce this review for them, because it's Rugby Sevens is quite an agility based sport, and there's a lot of ACLs in it. So I wanted to try help out the Sevens and give them some markers and some guidelines onto what to look for. So the players themselves would benefit because obviously they're the ones who are not going to be injured and not going to suffer the long rehabilitation process. The Australian Rugby Sevens medical and S&C and coaching staff too are also stakeholders, because I wanted to inform them of my findings and help them change their practice. And then the Australian Catholic University Masters staff and also myself is another stakeholder in this project. So in terms of what I did for my project, I did a narrative literature review. So I just looked at all the studies published on this topic up until July 2017, so up until very recently. And I looked at a lot of different databases, so Medline, Sonal, Sport Discuss, and Pedro. And I just tried to find every study I could on risk factors that included modifiable risk factors, and there was a fair few to go through, and so I think I have quite a comprehensive review. And the project itself will be analysed and evaluated by the S&C staff at the Australian Rugby Sevens, where I'll be presenting to them in the coming weeks, and also obviously by a staff member at ACU. The S&C staff will give me a bit of feedback about what they thought about it, just probably more qualitatively, and obviously the ACU staff will be analysing it more quantitatively as well and giving a bit of feedback too. So yeah. So in terms of the outcomes of the project, there was, as I said, there was a lot of studies out there, not too many of a high quality in nature. So most of them were case control or associative studies, but not actually prospective studies that looked at a group and measured them for something, and followed that group and saw how many people that were that got injured that were involved with something that they measured. So while there's a lot of different things identified. So they looked at neuromuscular control during both jump, landing, hopping, and cutting or stepping tasks. Hopping performance too. That was a big one for return for the preventing secondary injury. Muscular strength, both quads, hamstrings, glutes, all around those areas, and also strength ratios between the hamstrings and the quads. Times in surgery is another factor that we can control when we release them based on their surgery. So that is a modifiable risk factor. Fatigue, which may also link to these movement patterns that may predispose someone to ACL injury. The more fatigued someone is, the more likely they are to display these movement patterns. And also cognitive factors too, including processing speed, reaction time, and also fear of re-injury. They're also very important ones too. So a more recent finding is that looking at your strength and hopping performance and comparing it to the other side at the end of rehabilitation might not be as valid as comparing performance to the opposite side at the very start of rehabilitation, because some researchers have suggested that as the rehabilitation process goes on, the opposite leg also deconditions a little bit due to the lack of ability to train both legs. So if you compare results to a deconditioned side, is that not testing the involved leg enough? Is that not really comparing it to a high enough standard? So there's been recent research that showed that comparing it to results of the other leg at the very start of rehab before surgery actually led to the group that got at least 90% on that result got injured less than the group that got to 90% of the other leg by the end of rehab. So it's very, very interesting new research, and it shows that we really still are learning a lot about ACL injuries. While there is a lot of research on jump landing mechanics, there's a lot less on other risk factors, so that's something to take into account too. We still need a lot more research on a lot of risk factors. Even though they're very popular, the Y balance, FMS, and star excursion, there's only been one study that looked at them in relation to ACL injury, and the rest have all just looked at generally non-contact lower limb injury and haven't done any sub-analysis to look at the relationship between ACL injury. So there isn't much to be said about them and their relationship with ACL injury, and so even though they're quite popular, there really isn't much of an evidence base for ACL injury in particular. So the things that I wanted to deliver to the Sevens and to be able to sort of talk about my findings a bit more, we're going to go through an ACL screening protocol I came up with based on the literature, and also some return to play criteria for preventing secondary injury. So in terms of the ACL screening protocol, this would be for people who haven't had an ACL injury before, and this is just trying to identify people who might be at high risk. So the first, we have a series of seven tests here that the research has shown fairly strongly that these would be potentially involved in ACL injury. So the first one is a drop vertical jump test, where someone stands on a box about 30 centimeters high and jumps off, hits the ground, and goes into a maximal jump straight away, and then landing that jump. And you want to look at their kinematics during that. So the things that the research has shown up consistently that tend to be related to ACL injury in terms of kinematics are trunk lateral flexion, so tipping to one side, dynamic knee valgus, so that knee collapsing in across the body, and also a low knee flexion angle, so landing really stiff and not absorbing that force properly. These three things have shown up a lot in the other tests too. So they're the three biggest things in my opinion, based off what I've seen in the literature, to look for. Then there's also, because pretty much all ACL injuries, apart from some sports like basketball and netball, they tend to happen more when you're landing on one leg or was stepping off one leg, it's very important to look at a single leg drop vertical jump test too, and that hasn't been done as much in the research. It's more been the double leg ones, but I really think there's a lot of validity to doing a single leg drop vertical jump and looking for those same things. Also, considering a lot of ACL injuries happen during sidestepping, I think it's important to look at a sidestepping task and filming it as well and looking for those same factors, but both in a planned sense and an unplanned sense, because we know that ACL injuries tend to happen when you've got a reactive element and you've got to process something and then perform. And so it's important to look at both and see how the kinematics changes between the two. And if it does a lot during unplanned, maybe there's some cognitive things that we need to work on. Another one that has a bit of validity is a single leg squat. Just to standardize it, you can go to 90 degrees knee flexion and 12 reps or so, just to have a bit of an indication of strength too. If they're struggling after 12, then maybe they're not quite as strong. And the same things we're looking for there. We just don't want to see that knee collapsing across the body and also tipping to one side, and you can tell a lot about neuromuscular control in that test. One study also showed that looking at hip muscle strength correlated quite strongly with ACL injury. So both external rotation and abduction strength, and we have some standards there for strength compared to body weight. External rotation strength was just measured in sitting, and abduction strength was measured in side lying with the leg abducted 30 degrees. Also, hamstring to quadricep strength ratio. The research has shown that on the whole, if your strength in your hamstrings is at least 2/3 the strength of your quads, then that's sort of where you want to be. You don't want to have these 2-to-1 strength ratios of quadriceps to hamstrings, because as we know, the hamstring muscle is an ACL agonist, and by that I mean that it supports the ACL because it pulls on the tibia posteriorly, which as the ACL prevents anterior movement of the tibia. If the hamstring pulls on the tibia posteriorly, then it's going to support that ACL. The last one is the ankle dorsiflexion range of movement, which is very important because our calf helps absorb force and it doesn't all get transferred to the knee. So the more range of movement we have there, the more force we can absorb through that area rather than it going to the knee. In terms of return to play criteria, we got a fair few that are the same or similar, but we also have some new ones too. So quadricep strength is a big one, a very big one that's shown up in the research, and we want it to be within 10% of the uninjured side pre-surgery. So that's what I was talking about before in terms of comparing results to pre-surgery, not at the end of rehab where it might have deconditioned a little bit. Same for hamstring strength, within 10% of the uninjured side pre-surgery too, and then therefore you can calculate your hamstring quadricep strength ratios off this as well. Now a big one in return to play that wasn't so much studied in initially is hop testing. And single hop, triple hop, crossover hop, and 6-meter time hop have all been studied. And it's very important that, again, looking at results between the involved side and the uninvolved side pre-surgery is going to be more important than the uninvolved side at the end of surgery, which is what this recent research is showing. So we want to look at the distances and want it to be within 10% of the other side pre-surgery. So that's one aspect. We also want to look at the quality of movement too and look for those same things as well as before. There's also a T-test, running out, across one way, across back, and then across to the center and running backwards within 10% of pre-injury scores if you have that data. If not, the research has shown less than 10 seconds is a good time. Then similar to the ones before, the drop vertical jump, planned and unplanned sidestepping, and single leg squat, they're all the same as same protocols as before. And then another couple, one for fatigue. We want to look at their endurance in aerobic and anaerobic measures, because if they're not as fit, they're more likely to go into these movement patterns that might be high risk for ACL injury. And also times in surgery too. We want a minimum of 9 months. The research has shown that after this point, there is less benefit in waiting more, but definitely up until that point, the injury risk drops a lot. From 6 every month after 6, it's still dropping 24% until you get to 9. So it's a huge thing to make sure the athlete waits to 9 months. In terms of limitations of this review, there is a lack of high quality studies, as I mentioned before, only a few prospective ones, and the rest have pretty much all been case control or associative, and those two types of studies can't necessarily predict pre-injury risk, because you might not know whether these things have changed because of the injury or whether they were causing the injury. So the cause-effect relationship can't be demonstrated as well there. There's also quite a low sample size in the studies that have been prospective, so therefore a low number of ACL injuries, and therefore the study doesn't have as much power because there's not as many injuries happening. Most studies also have been on females, so the results are not necessarily applicable to males. And also most studies have been done on recreational level athletes, so it's unknown whether this transfers to elite athletes. There's also been some contradictory results on certain risk factors, for example, the drop vertical jump results. So it's very difficult to draw conclusions. Some studies have shown that the landing error scoring system does correlate, and some have shown that it doesn't, and it's hard to know why that's the case. Finally, a narrative literature review is subjective in nature in terms of the way that the studies are picked and how they're analysed and the conclusions that are made. Even though I tried to be as objective as possible, there obviously will be some elements of subjectivity or bias that do come into this. In terms of limitations of implementation, there are a few. So the time and resources taken to actually screen these athletes, looking at the test before, we had 7 and 9 or 10 different screens for each one, and that takes a long time. We're talking about 30 to 40 minutes per athlete, and then often we need 2 people per athlete as well, two coaches per athlete, one to look at quality of movement and one to look at quantity. So it's a fair big time commitment in a big squad of roughly 25 to 30 players. Also, a lot of the strength testing has been done in the research on isokinetic machines, which are not very available for high performance sport, who mainly use dynamometers and that sort of thing. So it's more of isokinetic's more of a research tool, and so we might not be able to know whether the results from handheld dynamometry transfer across. Also, we may not have the pre-surgery or pre-injury data for any athletes that are currently in rehab, so it's hard to use some of those return to play criteria that I've come up with if you didn't get that pre-surgery result. So that's another limitation. Also, we know that movement quality itself is quite difficult to measure, and a full-blown kinematic analysis, while it's useful, it's very time-consuming and also not readily available. So coaches often have to just film the athletes doing the movements and use their own clinical judgment. But then this leads to questions like, well, he's demonstrating a small amount of valgus, but how much is too much, and how do we know? And these are things that need to be clarified. And finally, there's some researchers that have posed the question: can we even predict injury risk at all? And I think that's a fair point. We can't say with 100% certainty, but I think that the research that I've looked at here, if all these things are met, then we can certainly say that there would be a reduced risk of injury, but not a guarantee by any means. In terms of recommendations for the organisation, I want the Sevens to use this data to screen their athletes for the initial injury, and to implement injury prevention programs to help reduce that injury risk for the athletes that do show up as high risk. In terms of the athletes in rehab, I would love for them to use that return to play criteria to help guide their decision making about when their athletes return to play. And I think that they should also try screen all their athletes in hopping and quadriceps and hamstring strength tests, so they have a bit of baseline data to use when and if an injury does occur. And also, I think that they should just continue, as they have been, to design a strength program that addresses a lot of these risk factors. So we're talking including single leg exercises for that control, jump and landing mechanics, and hammy and glute strengthening. So as they do, I think they should continue doing that. In terms of recommendations for professional practice, I think this is quite a big one, and I think a lot of physios working in private practice who are working with athletes often don't have as rigorous enough return to play criteria. They simply adopt more of a time-based approach and do a quick measure of range of movement and strength, and say, all right, you're on your way now, you can return to sport, when really that might not be enough. We need them to look deeper than that, and should try to assess them, or get someone else to assess them according to the demands of the sport they're returning to. So this is where working with S&Cs can be very useful, because they understand that demands of the sport. Also, I think there's benefit in encouraging ACL reco patients to come in before their surgery, so you can do that baseline hopping and strength testing. And finally, there is a big market for injury prevention, because we know prevention is better than cure, and I think that athletes that are involved in high-risk sports and who exhibit risk factors should be given these neuromuscular control programs, which have been shown to reduce the risk of injury. So in terms of some final conclusions, we definitely need a lot more research on this topic of modifiable risk factors, especially in terms of the qualitative side of things. We need to find some thresholds or ways to determine how much is too much in terms of the kinematics, and make it simpler for coaches to measure. That would be fantastic research to have. Also, from this, we can sort of tell that ACL injury risk is determined by many factors, and so that's why sometimes the research on just one factor might be mixed, because there's different demographic and there's different background of the patient. So there's both modifiable and non-modifiable risk factors for ACL injury. Currently, there really are only a few criteria with a very strong evidence base to help guide return to play. So that's why just measuring a lot of different things, functional, clinical, and subjective tests, is a smart idea, because that way we're getting as much information as we can and try to make a big decision based on a lot of data. Nonetheless, though, the three that do show up a lot are quadricep muscle strength, hopping performance, and that control in jump landing, hopping, and stepping. They do appear to be very important risk factors for return to play. And it definitely does appear too that the risk factors for initial and secondary injury are the same. So it's the same sort of biomechanics and the same weaknesses that may predispose injury to both. So it's important that we recognise that it's common to both sides, and the things we can be looking for in return to play are the same as what we can be looking for in preventing injury in the first place too. Finally, here are just some of the references I've used, and I hope you enjoyed the presentation.